Welcome back. In this block, we're going to review the toxicities of these older cytotoxic agents. And as we look at this, there's a lot of them. I think it's important, though, for you to recognize, and we'll emphasize here, which ones are the ones that you need to be aware of as a clinician who's practicing and maybe inheriting a patient on your doorstep with one of these toxicities. You know, which agents cause them, how they present, how we manage them. Okay, so we'll try to focus on the ones that are more pertinent to you practicing, not necessarily in the oncology suite, but inheriting the patient who's just recently gone through or has in the not too distant past gone through chemotherapy. To sort of wrap out the GI toxicities, one of the things you'll worry about is mucositis. Mucositis or stomatitis is inflammation of the digestive tract, mucositis around the mouth, and stomatitis, mouth, tongue, gums, roof of the mouth, and like. And this can be seen with some chemotherapy or with radiation. And it can present in various ways for patients. It's often painful, it's irritating. They get very sensitive to foods they eat, hot and cold, for example, particularly hot can affect it, spicy things can affect it, bleeding can be a problem. And it can even affect their ability to want to eat nutritionally or even breathing if the inflammation is enough. So really important for us. The duration, typically it's often self-limiting, but depending on the nature of the thing. But here it is with chemo, it's self-limiting, but it's going to be more common in the week or two after chemo. And lo and behold, 3 to 4 weeks later, they're coming in for another round of chemo. And so that's a problem. And with radiation-induced stomatitis, the duration of that is longer. So what are we going to do to manage this? Well, one is, you're going to recognize it when you see it. And then you're going to encourage folks to do the kind of dietary things. So avoiding irritants, spicy, hot foods, cooling foods, popsicles, sugar-free popsicles are really helpful for a lot of patients. But if they're neutropenic, you want to also have them encourage them to consider anything that could pose a risk for infection. So typically for folks who have significant stomatitis and are neutropenic, in that window of time, a couple of days to a week or so after chemo might be a fair number of patients, we look at avoiding raw foods, avoiding salads, avoiding raw fruit. That's kind of classically been done. We consider that neutropenic precautions. The dilemma, the degree to which neutropenic precautions, absolutely are implemented depend on the scenario. And I've seen varying settings kind of make different assess the risk for that. But I think as a group, a general principle, now is not the time, when you have stomatitis to eat things that are known to be sort of risky to use. So, kimchi things or things that are probiotic kind of things might be sort of more problematic. I'd avoid sort of naturally sourced foods that could be highly contaminated as well. Cleaning of the mouth is helpful as well. Soft toothbrushes, using swabs, non-alcohol-based rinses, or normal saline. And then pain relief. Very commonly, systemic analgesics we'll use. We do want to avoid nonsteroidals and aspirin, both for bleeding risks, and in a bit we'll talk about why we avoid them for masking fever if someone's neutropenic. Very commonly is something called magic mouthwash, which the formula for magic mouthwash is different depending on where you practice. Classically, magic mouthwash contains lidocaine, a local anesthetic, Benadryl, diphenhydramine, and Maalox, an antacid, which affects pH and sort of coating, a little bit of a coating effect. That's sort of the standard ingredients in magic mouthwash. Sometimes added to that or independent of that, we add something like nystatin or an antifungal to that. So some formulations include that. Some formulations include, other things as well. But you kind of want to recognize in your own setting what constitutes magic mouthwash. When you order that, it's not necessarily the same thing every place. Okay, but that's a pretty common management for stomatitis. Okay, so that's our GI toxicity. In a bit, we'll go on to some bone marrow suppression things. We've already given a bit of an overview of bone marrow suppression, but let's go a little more in depth on it and the kind of concerns we have as clinicians. We both want to look at both prevention of a problem and also managing when it happens. So the targets here we're most concerned of are probably the neutrophils, but also platelets and to some degree red cells as well. So let's kind of talk about each of these sort of in sequence. As we alluded to, anemias are usually less problematic compared to other bone marrow suppression we see with chemo. You might see a drop in H&H, which is common in patients, either related to the cancer or related to the therapy. But despite that, and you might be thinking, okay, they've got uh, significant anemia, let's give them some erythropoietin and maybe iron supplementation like we do with renal failure patients on dialysis, for example. Um, there's less benefit noted with cancer patients when we give erythropoietin, and so it's largely been sort of avoided. Giving erythropoietin with cancer patients was pretty common a decade ago or so, but less common now in practice, and so we don't really do this as an often situation anymore. Thrombocytopenia, on the other hand, is more concerning to us. Typically, the nadir we see is typically within a week or so after their chemo. And we might see it drop dramatically. And that's going to impact us in a lot of areas. We're going to be concerned about patients who have bleeding risks already. We're going to be concerned about patients who have a pre-existing thrombocytopenia, for example, that gets exacerbated by the chemo, might be alcoholics, for example, and particularly going to be concerned about our role of giving anticoagulants for patients who have thrombocytopenia. Keep in mind that a lot of our anticoagulants we're going to use for patients are going to be in folks who have a higher risk for clots, who have a hypercoagulable state, which is true for a lot of cancer patients. So they have a clot risk, but their thrombocytopenia may mean that we need to consider interrupting that anticoagulant therapy for a period of time while they have significant thrombocytopenia. They might also benefit from a platelet transfusion, particularly if their platelet counts are almost nil or they're very high risk for bleeding. Neutropenias are probably the major risk, at least as a clinician, for what I see for patients coming into the hospital. Our concern is the risk for infection, and the nadir for white cells, neutropenia states, is typically within a week or so after chemo. And we're most concerned about neutrophil counts going dramatically down. Our expectation is that you will be able to, in any patient, calculate an absolute neutrophil count. Sometimes the lab will provide that directly for you, but sometimes they won't. You need to be able to interpret what an ANC is, how to calculate it, and what the number means. We're really concerned when we look at basically to calculate an ANC, you take the total white count and then you multiply it by the percent of bands and segs, the percent of immature white cells. That's your absolute neutrophil count. And that's going to be done in you typically automated in most electronic medical records, but you need to recognize that ideally you want it above 1500. And then below 1000, we start to get worried. And below 500, we get more worried. And when it is, below 100, we get really worried. Okay, so we want to be worried about infection in those situations. So our sort of stratification of mild to moderate to severe neutropenia listed here. And typically in these patients, if they come in ready for chemo and they're already somewhat neutropenic, we'll hold therapy. So here are some guidelines that were historically used and pretty much used in a lot of settings across the country of when to hold chemo. So the day somebody comes into chemo for chemotherapy, they typically get a quick set of labs done while they're waiting to get their chemo, either that or sometimes right immediately the day before, which kind of tells people, do you come in for your chemo today or not? If their ANC is below 1000, if their B1 is elevated, their renal function's poor, they've got a very low hemoglobin, platelet, or white cell, those are usually indicators that the patient will have their chemotherapy held. Now, there may be a circumstance in some of these cases where the numbers aren't that low, and if they miss their chemotherapy, their risks for missing chemo and their worsening cancer is sort of outweighs the risk for toxicity. So it's not universal. And sometimes if the therapeutic intervention doesn't cause a major impact on bone marrow suppression, then they may move forward with their therapeutic regimen. Or the clinician may adjust the dose of the regimen or select only certain elements of that regimen that are less bone marrow suppressing. But as a general rule, you should be aware, and you may be asked to partner with the oncology team to schedule these pre-chemo, pretty immediately pre-chemo lab sets to evaluate the risk and the benefit for holding chemotherapy for patients. We also can use colony stimulating factors, and the major one we're going to use is granulocyte GCSF or filgastrin or longer acting filgastrin, which is called PEG filgastrin or Neulasta. Those are really the two major agents we use. Filgastrin, there are a number of biosimilar agents that are now available, meaning they don't have the exact chemical structure of the original Neupogen, but they are very close. They work very similarly, and they're much less expensive. Pegfilgrastim Neulasta typically costs around $2,000 for a dose. And so that a lot of settings are looking at using alternatives to that. And depending on the setting, they're going to use one or more of these agents to manage the patient they've got. But we will use these agents particularly for patients who are at very high risk for febrile neutropenia before or having a significant neutropenia before they get it. So typically these agents are given, particularly the long-acting one, is given the day after someone finishes their cycle of chemo. The short-acting ones might be given the day after plus sequential days thereafter because it's short-acting. But they're going to be sort of picked for the agents who are at highest risk for febrile neutropenia or patients who have had febrile neutropenia in prior cycles. So the data typically depends on the nature of the agent that was given, how much suppression there was for bone marrow suppression. But these agents have a long, and this is old data, but it's pretty well established, a long history of reducing deaths, morbidity, and mortality associated with neutropenic risk in patients on highly bone marrow suppressing regimens. The different agents that are chosen and how they're chosen is determined by the oncology team. And the patients who are candidates for them are going to depend on what their risks for bone marrow suppression are, what their risk for febrile neutropenia is, and the regimens that they're getting. So it's a decision that's made typically by the oncology team, not by the primary care provider. And as we'd expect, there are specific guidelines that periodically get updated, and the ASCO guidelines are listed here, and here, and here, 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 and here. Are you going to ever be expected to know these? Of course not. You're going to defer to the oncologist when a patient has neutropenia who may or may not be a candidate for a colony stimulating factor. But if you have a neutropenic patient in front of you, you may want to contact the oncology, you probably will want to contact the oncology team and or the infectious disease service to determine whether or not there is a role for colony stimulating factors for this patient now or at least before their next cycle of chemotherapy. So filgastrin, it's a human granulocyte colony stimulating factor that stimulates the bone marrow to produce more neutrophils. It does it pretty effectively. It's used to prevent infection, maybe to manage an existing infection, but folks who come in already with an infection and neutropenia, these take a couple of days to really kick in, so they probably don't offer that much benefit for the patient who's infected right now. They do better in preventing a future infection, not treating an existing infection. So they have a clear role, but you probably want to check with the oncology team about where they fit. Their half-life, the shorter-acting filgastrin agent has to be dosed pretty frequently. The longer-acting pegfilgrastim is a one single dose day after chemo. There are a couple of other agents that could be considered. The older granulocyte macrophage colony stimulating factors, an older agent that I've not seen clinicians use very much. So we don't see that used. And the colony stimulating factor for platelets associated with so much toxicity, it's just not used. Okay, so as you're sort of looking at all of these regimens, the role of where they fit, who gets them, how they get them, really again is in the purview of the oncologist. The prevention and the treatment of febrile neutropenia, though, is something that's going to end up on your doorstep. And you need to kind of recognize how, and the strategies for febrile neutropenia, how it presents, how it sort of gets manifest, and how we manage it. That definitely is in the purview of what you need to do. Now, you're going to pull in the oncologist and the ID service right away, but still, you need to treat this as a medical emergency. So febrile neutropenia is particularly defined as a fever in a patient with a low absolute neutrophil count, particularly below 500, or fever in a patient with an ANC below 1,000 when you predict it's going to go below 500, or folks who have very high temperatures, which is defined as a fever, typically more than 100.4 Fahrenheit, and or for at least 1 hour of a single record of over 101. And then other sort of variables. But we consider this a medical emergency for infection, and you get on it right away. So you do not want this patient sitting triaging in the waiting room of the emergency room. We treat this as a medical emergency as much as chest pain or an evolving stroke. You kind of need to think of this in that sort of same ballpark. So you need to recognize if somebody's gotten recent chemo and they come in with a fever, they go right to the front of the line, and we look at managing that. Because if we don't manage their infection, about a quarter of them have bacteremia, and their mortality is dramatic if we don't do something about it. So you remember we talk about the Surviving Sepsis campaign. All those same principles go right here, except we are sort of a broad net of what are the possible sources of infection. Well, stop here and think about somebody presents with a fever and is neutropenic. What are you going to look for infection? Well, the only thing that they may mount for a sign of infection is a fever. They may not mount inflammation at a particular site. Why? Because neutrophils are key involved in inflammatory processes. So you don't see purulence, you don't see erythema, you don't see, other sort of classic presentation with inflammatory markers related to their infection because they're neutropenic and they're not producing many of those. The other issue with patients on chemo is we routinely will look at avoiding giving anything that's going to blunt their temperature and a fever. Why? Because if they could become neutropenic, the only sign that they're going to be infected is their fever. So many patients who go through chemotherapeutic regimens, particularly ones that pose a risk for bone marrow suppression, those patients are instructed not to use acetaminophen nonsteroidals. Avoid nonsteroidals for bleeding risk, but we avoid nonsteroidals and we avoid acetaminophen because we want to know if they have a temperature, because that could mean they have febrile neutropenia, for which we need to assess their infection risk and we need to manage with broad spectrum empiric therapy for their infection right away. Okay, so all of that sort of goes in the mix of our thinking about patients, and that is true. Every clinician needs to be aware of this, whether or not you work with oncology patients. The prevention of febrile neutropenia related to colony stimulating factors we already talked about. Some clinicians, depending on the nature of their chemo and the guidelines and the nature of their infection, might be on prophylaxis with maybe a quinolone, levaquin, ciprofloxacin, maybe antiviral therapy with acyclovir or valacyclovir, maybe with Bactrim for PCP or PJP pneumonia. So there's going to be regimens that are going to be in place for these. These are typically in the purview of, again, the oncologist to decide, maybe in conjunction with the infectious disease service. You may see prophylactic antifungals used for a certain subset of patients. It's not routine, but it is for folks who are at high risk for invasive fungal infections or significant candidial infections. And sort of the empiric treatment of patients who are neutropenic are, depending on what their risk for particular agents are and what agents are used for the initial treatment of febrile neutropenia. The classic regimen that we see used universally for bacterial coverage in a febrile neutropenic patient is either piperacillin and tazobactam plus vancomycin or cefepime plus vancomycin. What you really want to cover are, as we talk about in other conditions, broad spectrum empiric coverage till you know more, but you want to look probably at anti-pseudomonal coverage, MRSA coverage, and broad spectrum gram-positive, gram-negative coverage. Adding on antivirals, antifungals as it sort of is warranted based on their response. You're doing all the things you're going to do with someone with septic, surviving sepsis campaign. You're going to do the lactate levels. You're going to do the full CBC and chemistry. You're going to do, 2 to 4 sets of blood cultures and culture anything else that you can possibly culture before you start antibiotics. But again, we're not going to delay antibiotics. We're going to get all the cultures we can possibly get. You're probably going to do all the imaging thing to help you decide what you could possibly be dealing with, but you don't really know. And you have to recognize that all the things that you're looking at that you would normally see in a patient with classic pneumonia or UTI or whatever else, you may not see in this patient because they don't make white cells. So, the inflammatory things you're going to look for, you may not see. The white cell that may show up in a urine culture, for example, or a urine sample, you may not see. So you need to kind of recognize that you need to catch a broad net and also recognize that, a lot of times you're not going to get anything coming back on culture. You're going to sort of just be treating empirically until they respond to whatever you're treating. Okay, so that's febrile neutropenia, and in my mind, probably the most important thing that of all the things you need to be aware of, because you have one chance to get this right, and you have to get it right at the get-go. Okay, let's move on to some other toxicities. One is tumor lysis syndrome. Tumor lysis syndrome, also an oncologic emergency. We'll see it less often, at least in our typical community hospitals, at least, than you might see than you'd see febrile neutropenia, but you'd still see it. And we're worried about the rapid lysis of malignant cells that then release intracellular components to high levels. We're worried about uric acid levels and electrolyte imbalances. And so because of those, we can see renal insufficiency, cardiac arrhythmias, seizures, all kinds of complications that can result in that. And we want to recognize both who can be at risk for this, when it happens, how to manage it. So the lysis of malignant cells leads to a number of different factors, and I don't think we necessarily need to go through sort of all of this, but this graphic, sort of a busy graphic, leads to, what are all of the amino acids that will sort of elevate to lead to uric acid development? What are the phosphate concerns, electrolyte concerns, potassium particularly? And what are the cytokine release going to do for hypertension, inflammation, and both acute kidney injury as well as all the other things cytokines can do in different kind of cytokine storm situations. So all of those are significant in tumor lysis syndrome. Most often the etiology are when you're giving chemotherapy that will lyse a lot of cells at one point in time, where these cell lysis will contribute to the release of all of these things all at once. That's mostly seen with leukemias and lymphomas. Most of the other types of tumor cells and types of cancers don't cause this nearly as badly as leukemias and lymphomas will, particularly lymphomas. And so our usual protocol is that we will do everything we can, oncologists will do everything they can to prevent tumor lysis syndrome, really in everybody, but particularly preventing or doing what they can to manage things and recognize this could happen in patients who are being managed for leukemias or lymphomas. So the highest risk are Burkitt's lymphoma, non-Hodgkin's lymphoma, and acute lymphocytic and myelogous leukemias. But the other kind of moderate and low risk issues are listed are issues here as well. The tumor mass and the tumor bulk can be an issue. Folks who have elevated white counts, who have leukemia and elevated white counts, again, there's more sort of cells that can sort of lyse, so that's an issue. And when there's bone marrow involvement or already an issue with renal function to start with. So the risk factors related to the high proliferation of cancer cells or sensitivities are listed sort of here. Pre-existing renal insufficiency poses a risk for more complications, so worry about that. Folks who are dehydrated is problematic. Hypotensive patients run into more problems. If they're under nephrotoxic agents, there's more complications and renal complications as well. If their baseline serum uric acid level's high, releasing more uric acid is going to cause a problem. When does it happen? Usually it's within 24 to 48 hours after they do their chemo. Sometimes it can be more delayed than that. And so we want to be aware of that as a patient presents to us. Their clinical manifestations might be nausea, vomiting, sort of non-specific. They might have cardiovascular issues, including arrhythmias. They present with worsening heart failure or hypotension or edema. They might have central nervous system mental status changes. They might have abdominal cramping or other kind of muscle cramping or tetany. And they present with acute kidney injury. The lab markers you're going to look for include elevated uric acid, potassium, phos, or a low calcium. And clinical findings include arrhythmias and or seizure activity. A very busy graphic for which we don't expect you to kind of have an appreciation for per se, but sort of lots of things going on with tumor lysis syndrome and lots of sort of things that clinicians are thinking about. So let's sort of talk through some of the strategies we'll use. In preventing tumor lysis syndrome, particularly in those folks who are going to, being treated for lymphomas and leukemias, or maybe breast cancers, other things where this is going to be more problematic, making sure patients are well hydrated, making sure that we're managing their electrolytes before they go in, managing their phosphate intake or administration as well. Those are going to be sort of clear issues. They might be candidates for urinary alkalization. This is commonly done with some regimens that they might even give during the administration of the chemo, a bicarb. And this is sort of used in a sense to change the pH in the urine. This isn't a common scenario, but that is sometimes done in situations where we're really worried about significant management of hyperuricemia or tumor lysis syndrome. So it's something that might be considered in management, a subset of patients. The other thing we do want to manage is their hyperuricemic risk. Most often we're going to do that in advance with allopurinol. So a lot of patients who have lymphomas and leukemias particularly, you may be thinking, why are they on allopurinol? That's for gout. Well, yes, it's for gout, but if they have pre-existing gout and hyperuricemia, you want to get that in good control before they're going in for the treatment for the lymphoma or leukemia. So you want to be aware of that. Allopurinol is sort of the standard agent we're going to use, and the typical dose for gout we're going to see is anywhere from 100 to 300 milligrams a day. In tumor lysis syndrome, though, you may see allopurinol doses very much higher, up to 900 milligrams a day. It's a very selective circumstance, but we'll do that pretty aggressively in patients who have tumor lysis syndrome. The difficulty is that we need to dose allopurinol for renal function. There are interactions and potential for hypersensitivity reactions. But all that said, allopurinol is pretty widely used and pretty well tolerated in the great majority of patients. The dilemma in someone who has active tumor lysis syndrome, though, is that allopurinol may take a couple of days to work. And so many clinicians will look at, before they go in for their round of chemo, uric acid management is done in advance of their chemo, and we want to make sure that they're on adequate allopurinol if they have hyperuricemia to start with. We talk in the rheumatology block about how we use allopurinol not with acute gout, but otherwise in patients with hyperuricemia, and you really want to manage that hyperuricemic state and gout well before someone's going to go in for their chemo. particularly chemo for lymphomas or leukemias. There is a role for other therapy, a limited role for rasburicase in folks who have significant tumor lysis syndrome with significant hyperuric acid levels. It has more hypersensitivity, it's expensive, so it's not sort of a first-line therapy, but in acute management, we'll sometimes see it used. So there's this agent, rasburicase, that is sometimes used by the oncology team acutely to manage tumor lysis syndrome. The reactions most commonly are associated with hypersensitivity. Officially, it's indicated only for, or historically only for, a single dose. There's been data to say repeated doses might be considered in a high-risk patient. So that's kind of evolved over the last couple of years, that it's, but we are worried about hypersensitivity reactions. So the black box warnings, including with this agent, it's not a drug to be taken lightly, and it's going to be evaluated by the oncology team in combination probably with the critical care team. We also want to manage hyperphosphatemia in tumor lysis syndrome. We're going to do that with phosphate binders, same kind of things we use in patients who have renal failure. We talk about this much more in the renal failure block. We manage hyperkalemia. We talk much more about this in the fluid electrolyte management block. We manage hypocalcemia. Again, we talk about this with the fluid electrolyte block. And we manage renal dysfunction and uremia, again, in the renal fluid electrolyte block. The last sets of toxicities we'll talk about here, we'll go through them quickly. One is the management of extravasation. This is the very drugs that are used to treat cancers. Many of the older cytotoxic drugs are very, very irritating to tissue, and not surprising that they are. And so their use, the old cytotoxic drugs can only be administered by a trained, certified nurse in oncology management who understands that the patient has a dedicated central or PICC line for their chemo, monitors for extravasation. You never give these drugs by a peripheral line site. The thing with extravasations you need to worry about is cancer chemotherapy not only does it, to a lesser degree, some other drugs that you'll be giving in clinical practice, if the line extravasates, are problematic as well. Things like vancomycin can be pretty irritating to surrounding tissue if the line extravasates. So as a clinician, you kind of want to be aware that if a line extravasates, there's a certain management strategy we will do. For chemo, this is only going to be done in the oncology suite, and they know how to manage it pretty well. But the principles apply in general to other extravasations as well. So the risk for extravasation depends on whether the agent is an irritant or a vesicant. There's a lot of them in oncology that are vesicants, very irritating, severe, irreversible tissue damage. They're only given by a particular IV administration process with a central line and only done by a trained oncology nurse. They will look at preventing extravasation by monitoring that directly and monitoring for any symptoms of extravasation, but this would be true for any irritating drug given IV. Edema, erythema, anything that else looks like it's not quite right. And there are certain procedures you'll do when you kind of you stop the infusing drug right away, and then you'll look at drawing back as much from you can before you remove that catheter. There might be an antidote that's administered depending on the agent that's given, be it chemo or not. You want to be clear about what that is. And for some drugs like the anthracyclines, like doxorubicin, daunorubicin, there is a particular dose of a drug that's given that's specific to that setting. So just know that the nurses would know that. Okay, but this is a real risk and a concern. Other kinds of toxicities, one is pulmonary toxicity. There are other drugs that cause pulmonary toxicity we talk about in the cardiovascular block. Amiodarone is one of those that can cause long-term pulmonary toxicity. In oncology settings, bleomycin, carmustine, some of the older agents, cyclophosphamide, methotrexate can cause pulmonary toxicity. And so we're kind of aware of that. The oncology team is usually pretty well aware of that. There are drugs that cause nephrotoxicity. The worst of these are probably carboplatin and cisplatin. We'll talk about these the in the acute kidney injury block, but we do that by avoiding other nephrotoxic drugs, and we also do it by adequate hydration in advance of giving cisplatin or carboplatin. We also worry about cardiotoxicity. There are a number of drugs that can cause cardiac toxicity that are given, the old cytotoxic agents. The worst of them probably are two broad groups. One are the angiogenesis inhibitors, Avastin. This is a drug that we'll talk about sort of in the next block, that will, or in 2 blocks from now, meaning in the immunologic therapies, that reduces blood vessel development. And so when you've got a tumor that relies on adequate vascularization to feed that tumor, well, gee, if you could interfere with blood vessel formation, then you would starve the tumor. So Avastin for some highly vascularized types of tumors has been used to actually do that. The problem is that, well, not only are you preventing the revascularization of tissue where the tumor is, if a patient's had an MI or risk for an MI, then the collateral circulation development that preserves their cardiac function is also inhibited. And so you really have to worry about folks who have coronary artery disease when you're looking at folks who use a drug like Avastin. The other issues are cardiomyopathies with 2 different groups of drugs. One is Herceptin, the other one is the anthracyclines. And in these cases, cumulative doses are problematic. Folks may require certain baseline monitoring for the cardiac status during and before future treatment. So the preventions might be we monitor lifetime doses of these drugs. We look at monitoring baseline and periodic assessments of myocardial function, particularly MUGA scans, particularly with certain drugs, are done, as well as tracking how somebody's cardiac status is. Hemorrhagic cystitis is seen with certain drugs. The subset you'd need to be aware of could be if somebody comes in with hematuria. Well, you want to ask the question, have they had recent chemotherapy for which particularly cyclophosphamide or ifosfamide are problematic here? And there are issues that we can do to prevent our treatment, including aggressive hydration and using a drug called Mesna. The combination with Mesna is very specific for isophosphamide, and we don't need to go in detail here, but the timing of it is important, I think, as clinicians, and how it's managed. Okay, so these are the major cytotoxic toxicities. We still use a lot of these drugs. You need to be aware of these and what it would be if one of these patients comes on your doorstep.